So, Ms. Roe Adams is the president and co-founder of Harlem Mother Stop Another Violent End organization. She also currently serves as the CAB advisory member of Sydenham, and she's a very active member of her Harlem community. So welcome. We're happy that you're joining us, and we look forward to working with you on the board.
Thank you. Thank you.
For the record, I would also like to know that Deborah Brown is representing Dr. Mitchell Katz. Dr. Michelle Morse is representing Dr. Ashwin Vasan. Erin Kelly is representing the deputy mayor, and Karen St. Hilaire is representing Gary Jenkins, all in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held January 26, 2023. Are there any questions or comments on the minutes? So hearing none, let me, should I call for a full vote or one by one? Paul. So let me then ask for your vote individually. Deb Brown,
Yes.
Erin Kelly,
Yes.
Dr. Calamia,
Yes.
Michelle Morse,
Yes.
Christina Chang, Karen St. Hilaire,
Yes.
Robert Nolan,
Yes.
Barbara Lowe,
Yes.
Frida Wang,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
and Jackie Rowe Adams.
Yes.
And I vote yes also. Thank you so much. So during the executive session, the board received and approved oral and written governing body submissions from NYCH and H. Lincoln. The board also received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Queens. And also during the executive session, the board received and approved the governance committee recommendation to appoint Manny Saez to the corporate officer title of Vice President for Facilities Development. So congratulations, Manny. And also, Article 6, Section 1C of the bylaws of New York City Health and Hospitals Corporation provides that the chairperson of the board shall annually appoint, with the approval of the majority of the board, the members of the standing committees of the board. Therefore, I would like to propose a motion to appoint Jackie Rowe Adams to the Community Relations, Equity, Diversity, and Inclusion, and the Quality Assurance and Performance Improvement Committees. So let me then ask for a vote. All in favor, please say yes.
Yes.
Opposed, say no. So
Got my work cut out.
you got your work cut out for you. Please also be aware that the fiscal year 2023 annual public hearing have been scheduled for each borough. These meetings will convene at 6 p.m. Staten Island will be March 21st at Staten Island Borough Hall. Manhattan will be April 4th at Harlem Hospital. Queens will be April 18th at Elmhurst Hospital. The Bronx will be May 16th at Jacoby Hospital, and Brooklyn will be June 13th at Woodhull Hospital. So members of the community are encouraged to register to speak by contacting the board office at 212-788-3360. And this information is also posted on our public website. So since we began the process of approving Vendex approval, since we began the process of approving contracts prior to Vendex approvals, there are 10 items on today's agenda requiring Vendex approval. All have that approval. There are 2 items from previous board meetings pending Vendex approval. Since we last met, 1 approval was received. We will continue to notify the board as outstanding Vendex approvals are received. And now we're going to move to the resolutions. So let's begin with the first one, number 4. I read that one, right? So number 4 in your agenda is authorizing the creation of 2 not-for-profit public benefit corporation subsidiaries to facilitate New York City Health and Hospitals Corporation taking advantage of opportunities consistent with its mission to expand the members currently served by its subsidiary, MetroPlus Health Plan, Inc., or MetroPlus, through the establishment of a subsidiary public benefit corporation to hold a license under Article 43 of the New York Insurance Law, and a second not-for-profit subsidiary public benefit corporation to function as a managed services organization, an MSO, substantially as set forth in the proposed certificates of incorporation and bylaws attached. And further approving the rosters of members of the board of directors of the two subsidiaries that appears in Appendix A attached to this resolution. And this was presented to the MetroPlus board on January 31st, 2023. So welcome.
Thank you so much. So I am Andrea Cohen, Senior Vice President and General Counsel at New York City Health and Hospitals. And for today's purposes, I'm sitting in for Dr. Katz, who very much wanted to give this presentation but isn't able to be here in person today. And my colleague, of course, you know, is
Callie Schwartz, President and CEO of MetroPlus.
And so today we are talking about a proposal, as Dr. Pagan just said, to create new subsidiaries to work with and expand our current MetroPlus health insurance business and programs. As we'll be discussing, H&H management views this as very much in line with H&H's mission to support both enrollees or members and patients and to help sustain health and hospitals as well. And we'll go over that in the presentation. So to begin, the formal request is to authorize health and hospitals to create these two new subsidiary corporations, one to hold what's called an Article 43 license and one to be an MSO or Managed Services Organization, and to improve the initial boards of directors of these two new organizations and the bylaws of these two new organizations. To give you some background, an Article 43 is a not-for-profit license under the insurance law to provide certain commercial health insurance products. Currently, our subsidiary, MetroPlus Health, holds a not-for-profit HMO license, which is called an Article 44 license. State law prohibits an Article 44 corporation from also offering Article 43 products, and that is why in order for MetroPlus to offer Article 43 commercial health insurance products, we have to create a new and separate subsidiary corporation. And then, since we're going to have two different corporations providing different kinds of health insurance products, to manage the distribution of resources between those two entities, those two subsidiaries, including things like cost allocation of employees, facilities, and other things like that, H&H is also seeking to create a third subsidiary, which would be the Managed Services Organization, or the MSO. The MSO would also be able to provide third-party administrator services for self-funded ERISA health insurance plans, which would be another line of business that would be open to MetroPlus through this arrangement. And as Dr. Bagan mentioned, the MetroPlus board has already recommended that the H&H board take these actions. So why does MetroPlus need to create new subsidiaries for the Article 43? So an Article 43 license in a new subsidiary would allow MetroPlus Health to issue what's called experience-rated products, which are attractive and affordable to many different kinds of employers for their employees and associations. So 3 examples that I think are on the agenda for MetroPlus to look at if it is able to create, if H&H creates these additional subsidiaries, would be not-for-profit organizations, many of which have contracts with New York City to provide social services. These groups that MetroPlus has identified have about 17,000 employees who might be able to benefit from this, from a new set of products offered by MetroPlus. Gig workers via an association could offer these kinds of products through MetroPlus. Those might be like rideshare drivers or other kinds of gig worker groups. And then finally, with an Article 43 license, MetroPlus could seek to cover parts of the city workforce through a proposal that MetroPlus has submitted with a national health insurance company partner in response to New York City's solicitation for health insurance for its employees and pre-Medicare retirees. And under that RFP from the city, a winning entity would have to have an Article 43 license. So MetroPlus wouldn't be able to participate in that solicitation if it didn't have an Article 43 license. So why is this a good idea for health and hospitals and for MetroPlus at this point in time? For one thing, let's talk first about mission. As you know, that is very essential and critical to what this board does and thinks about. The new license will further the H&H mission of providing quality access to comprehensive care and treatment, physical and mental, to all New Yorkers, including for some underserved groups like cash-strapped, not-for-profit social service entities seeking to provide affordable health insurance for their workers. So just to put a point on this, we very much see this as in line with H&H's mission to expand health insurance and health services to New Yorkers. Second is, the second reason is relates to finances, expanded opportunities for MetroPlus Health by creating these two subsidiaries and the lines of business associated with them may provide financial resources that could sustain both MetroPlus and health and hospitals during difficult economic periods. Third is that it's very much the industry norm to create separate subsidiaries for these different lines of business and to have an MSO that helps to allocate work and resources between them. Most of the health insurance organizations that you have heard of that operate in the city and elsewhere have this structure of multiple corporate entities to handle this kind of work. It's also a reflection of MetroPlus building on success it's already had. Its Gold Care large group product launched in 2016 for daycare workers. The product offers comprehensive benefits with minimal cost sharing to daycare workers. And this is a model that could move more to scale with a new arrangement with an Article 43 license. And finally, in terms of capability, MetroPlus is now in a place that it is well positioned to take advantage of these new opportunities because of current financial strength, a reputation for quality that has continued to grow, and a proven successful track record. So the proposed corporate structure is depicted here. H&H, this board would currently has already created a subsidiary, which is the, on this picture described as the Article 44 corporation. That's MetroPlus Health as it exists today, but it would create two other subsidiaries. Both would be wholly owned by health and hospitals, and they would each have a board, which we'll describe shortly, the membership of the board. Much of that is determined by different regulatory requirements, but in all cases, the goal is to have the boards align as much as possible across the three entities. The proposal is that Dr. Schwartz would be the CEO of all three entities. And then they would these different entities would have different sort of functions, one to offer Article 44 HMO plans, one to offer Article 43 commercial plans, and the MSO to help allocate work between them, hold certain kinds of contracts for both entities, and also potentially to offer TPA or third-party administrator services for ERISA plans potentially. So a moment about board membership of these two new entities. So we're asking the board to approve initial members of the boards of the two new subsidiaries. These setting initial boards is necessary to take the next steps in getting both incorporated and to get a license from the Department of Financial Services to offer an Article 43. And we should say that a fuller slate of board members for the Article 43 will likely be offered at the next board meeting. We have, as you can see in your materials, there'd be 3 initial board members, but a fuller slate for the entire board would be offered up to this board at the next board meeting. So the existing MetroPlus Health Board has 9 members. 5 of the members are also either members of the H&H Board of Directors. As you know, Dr. Sally Pinheiro is the chair of the MetroPlus Health Board presently. and the other 4 are officers or employees of health and hospitals. 2 members of the MetroPlus Health Board currently are individuals who are covered by a MetroPlus Health plan. The proposal is that the new MSO subsidiary would have the same members as the current Metro Health Plus board, but it would not include those plan members because the MSO doesn't offer a plan. So it would have 7 members, and they would be the same 7 members who are currently on the MetroPlus Health Board. The Article 43 Corporation, the other new one that we are seeking to have authorized today, has some very specific regulatory requirements from the Department of Financial Services about the makeup of their board members. They would have to have at least a 13-member board, only 3 members of which could be either a board member or an officer of health and hospitals. 6 members would have to be individuals covered by a plan offered by the Article 43, the 3 health and hospitals officers or employees could actually count toward that number. So a moment on MetroPlus Health's many successes to date that we think support its position to be able to make this important investment and move forward today. So for one thing, MetroPlus is at an all-time high of members. There are 717,000 current members, the highest enrollment ever. It's had an increase of more than 200,000 members in the past 3 years. And although that is extremely rapid growth for the corporation, operations and performance has continued to go extremely well. MetroPlus Health received its highest quality score ever in Medicare, a 4-star rating from CMS. That would be for 2022 or 2021, or the
For 2023.
for 2023. A very significant milestone. Despite pandemic challenges, it successfully insourced behavioral health coverage in October of 2021. This board was very much involved in approving the conditions to make that happen. It has the highest Google review rating ever at 4.1 stars out of 5. And it has gotten 30 industry recognition awards just in 2022. So very impressive track record. So in terms of the structure of the new subsidiaries, is that the H&H Board of Directors would approve the articles of incorporation and bylaws for 2 new subsidiaries with the following corporate names. The Article 43 Corporation would be called MetroPlus Health Gold Incorporated, and the Managed Services Plan would be, Managed Services Organization would be called MetroPlus Health 1X Incorporated. The articles of incorporation and the bylaws would follow the same basic structure as the existing MetroPlus subsidiary. So all 3 subsidiaries would be wholly owned by health and hospitals. All of the board members would be appointed only with the approval of the Health and Hospitals Board, and they would serve at the pleasure of the Health and Hospitals Board. Any board member could be removed of one of these subsidiaries could be removed by the Health and Hospitals Board. And the articles of incorporation and the bylaws have the same requirements as the MetroPlus board in terms of limitations on what the subsidiary can do and can't do unless it gets health and hospitals approval. So there's a list of conditions that include things like a change in corporate structure, a change in the bylaws, disposition of property, approval of large contracts. All of those things would be things that the subsidiary would have to bring to the Health and Hospitals Board for decision. So one of the conditions for getting an Article 43 license is approval by the State Department of Financial Services. And in order to get that approval, MetroPlus has to have a certain amount of reserve funding available. And the plan for that reserve funding is as follows. The existing MetroPlus Health Corporation would provide the necessary funding to the new or the proposed MetroPlus Health Article 43 Corporation. Under current projections, it's anticipated that the amount of the required funding could be about $90 million. $60 million of which would be for projected new members, and $30 million of which are currently in reserve for gold members from the existing Article 44 to the Article 43. MetroPlus Health has sufficient funds available to provide these funds for the necessary reserve, and therefore there would be no financial impact on health and hospitals directly by these funds being put in reserve by MetroPlus Health. So all of the funding comes from within the MetroPlus Health
Unassigned
current,
reserve.
yes, unassigned reserves. Thank you. So with all of that, the proposed resolution, which I will not reread unless somebody would like me to do so.
Please no.
I know that a lot of detail has been provided, but essentially the resolution is to ask the Health and Hospitals Board to approve the creation of these two subsidiaries along with the attached bylaws, substantially those bylaws, the certificates of incorporation and initial board members, and that is the proposal there for your consideration. Welcome any questions.
Thank you. Any questions?
This one. Thank you, Andy and Talia and Steve. I think this is really just amazing and terrific, and kudos to MetroPlus and the chair of MetroPlus, Sally, for all you guys have accomplished and done. So just really terrific. I do have a couple questions that I thought might just help clarify some things for me. So I understand the difference between the 43 and 44, I think, but I'm just, how would you describe that? That the 43 is the governmental plans, and the 44 and the 43 is the commercial plans, or is it just experience rated versus community-based charges, or what's the main differentiating factor between the two plans?
You want to take that?
Yeah. So yes, Article 44 is what we call community rated, and Article 43 is experience rated. What this means is that in Article 44, anyone in your geography who qualifies as a large group, meaning more than 100 employees, can buy into the product, and the premium is being set based on average of all of the lives that are being covered from multiple groups. In Article 43, it's experience-based, meaning a group pays the premium that reflects its own experience. It is not based on the entire community. So if you have a group that is healthy with insignificant morbidity, their premium will be lower. If you have a group that has higher morbidity, their premium will reflect their needs. So it is individualized, it's not mixing, it's not an average of the community, it reflects specifically the group.
And then also the government products are also in the Article 44, right?
Right, so the way we're structuring it is that the government sponsored products will be under Article 44. The commercial products will be sitting under Article 43. All of this will be non-for-profit, regardless of whether it's government-sponsored or commercial.
And we have the current gold product. Is that a commercial product? Is that considered a commercial product? But it is under 44 now.
That's right.
But
So
its premiums
gold-
are charged at a community-based.
Right, so, right, Gold and Gold Care, those are the two commercial products that we currently have. And they are, you're right, in Article 44, so they are community-based, right?
But in the plan is to move those all to 43, and we'll have them separated that way, and then
That's
become
right.
community-based, and then, or excuse me, experience rated. So if that's the case, then we don't have any experience rated plans currently, right, that we manage or run. Is that-
Right. I mean, essentially, we do not, because we do not have Article 43.
So are you concerned at all about that transition in terms of having to now do a experience-based, experience-rated rate setting?
So we are heavily relying on a reputable actuary firm who has been supporting us through all of our products for many years. And the actuary firm has extensive experience with setting rates and making financial assumptions for experience-based products. So we're relying on them. They've done this with our competitors. We have been, in preparation for this meeting, working with them and doing some legwork. So we are comfortable that with their support, we will be successful in doing Article 43 experience-based.
Okay. And so does that tie into, if the reserves that we have to establish for these plans, does that depend on how our experience rate setting is performing, so that will affect the level of reserves we would have to set aside, or how does the reserve calculation work?
So I'm going to ask Lauren Leverage, our CFO, to answer that question.
Hi, good afternoon, everyone. So the reserves set forth by the Department of Financial Services are large in part a percentage of your premium that you're covering those lives. So there will be a 12.5% reserve requirement. We are moving, as Dr. Schwartz alluded, for the existing gold and gold care lives from the 44 to the 43. So there will be an anticipated transfer of those reserves currently held within our balance sheet from the 44 to the 43. We have evaluated the cost for the new lives that we believe are part of the assumption for the city negotiated acquisition, and that is also driven by the 12.5% of revenue. There could be additional premium reserves required by the DFS, but the regulatory base starts at 12.5%.
So if the experience rating determines that we need to charge higher premiums, for example, then the reserve level
And you will
might
need higher
go up.
reserve requirements. That is
Okay.
correct. It's reset on an annual basis. I will also say any rate filing that we put forth for an experience rated product is approved by the Department of Financial Services. It goes through a level of desk review, network adequacy, and various other components in order to make sure that you have a regulatory approved product to bring forward for that group. It gives us control around the premium that we set for that group so that we are not commingling groups and we are able to better support the missions of those smaller entities, like the daycare workers that we offer today. Their nature, that we're able to offer them
Right.
a better premium.
And then 90 million is based on the current gold members that you have, and then what you anticipate from if there's if we're successful in the city's RFP. And I think part of the goal here is to potentially offer commercial products for other nonprofits and small organizations that are struggling. So that those amounts, we would need to have additional reserves set aside for additional lives that we would be covering. Is that right?
Beyond our initial assumption, our first assumption out of the gate has to be a 4-year projection. So where you think you will land at the end of those 4 years, those members and the value of that reserve requirement that needs to be put up on day one.
So this is a projection beyond just the RFP for the city that you guys have made.
Yes, it includes the small groups as the daycare workers, the gold products, and the city product.
Great.
Mr. Adams, you had a question or?
Yes, well, first let me say congratulations to you all because you're doing wonderful work, and I thank you.
Thank you.
My question, I didn't hear too much about the retirees. Does this include? Okay,
This
I
is
know
not-
I didn't hear something. But
Ali and then and Vincent.
Yeah, congratulations to you, Dr. Schwartz, and your whole team. I had a question concerning, you've done a remarkable job increasing your membership in sourcing behavioral health. But I just wonder, do you have the bandwidth to handle this kind of expansion and growth over the next 4 years? Do you see needing more employees? Do you see needing additional revenue of any kind?
Yeah.
Are you just tired?
That goes without saying.
All of the above. So out of the gate, the plan is to use current staff and current executive staff to manage the 3 subsidiaries. So while we are getting established, getting all of the licenses, getting all of the approvals, policies, procedures, etc., we expect the current staff to handle the 3 subsidiaries. Down the road, if we grow significantly and add significant membership in any of those 3, yes, down the road, I do see ultimately the staff growing to support that operation, but I do not see it happening in the foreseeable future, meaning, later this year. So all of this year will be focused on approvals, building process, et cetera, and getting the business. Once we start significantly growing, not a few hundred additional members, but many thousands of members, yes, there will be a need to scale up to support the volume.
Yeah, sort of apropos to that, how distinct do the 2 entities have to be? And I'm thinking in terms of financial reporting and so on. Just to the point you're making, you're going to be sharing services. Do you have to allocate? Do you have separate financials? Is there consolidated? How does that all work in this?
So currently, MetroPlus's balance sheet does roll up to H&H's. So in this structure, there will be an allocation of administrative costs across the subsidiaries based on a percentage of time worked in that line of business. And in the Article 43, there are additional requirements for reporting on the fiscal side with the Department of Financial Services that does not exist today. Under the 44, and that will be a new requirement for the organization.
Okay. Okay.
Congratulations early on. I'm just wondering how the medical care and the whole process of getting that care from enrollment on back. I don't want you to go through all the details, but I'm comparing that to what we currently have, which is kind of difficult to wrap our arms around, those of us who worked in the systems in the city. We don't know about things happening and things like that, but at the same time, protection of longevity and things like that are important as well.
Right. So you're referring specifically to kind of the medical management piece, preventative care, and then care for chronic conditions.
Yeah. Plus the whole umbrella, the whole umbrella of the structure of the insurance.
Right. So I think you're referring to the difficulty in terms of the bifurcation that exists today, where the professional, on the emblem side, the professional side is covered by emblem, and the facility side is covered by Empire, right? So there's a bifurcation, and it might be a little confusing for some. So I am prohibited from sharing specifically how we are thinking about our partnership and the approach. I will just say it is different from what is currently offered. In terms of, so because it is different, we believe it will be more straightforward. In terms of preventative care and management of chronic conditions, this is something that we really got, our reputation for. This is why we were able to get to 4 stars, and this is why we have been performing very well in quality, because a lot of the quality measures are actually focused both on preventative care and management of chronic care, specifically around diabetes. So this is an area where MetroPlus has strength in. And so the ability to potentially expand that strength to more members, I think is definitely part of the appeal of us being in this lane, right, and competing for more city business.
If you don't, just one more thing. The level of protection for employees and their insurances looked like it was whittling away over the last couple of years. Rates went up, different insurance groups were charging extraordinary prices for eye drops and things like that. How will you continue to try to protect some of the affordability of your insurance?
Yeah. So I think we are known as the affordable insurance, and we do it in several ways. Number one, we're focusing on prevention, and we're known for it, and management of chronic conditions. Number two, I think we're discretionary in how we build our network and who is in our network and who is not in our network. And number three is we're also discretionary in how we negotiate our contracts. And I think one of the most important reasons for us being successful and cost effective is because of risk arrangements that we have with providers. So providers are incentivized to provide good quality of care and to do it efficiently, and then we share in the savings. So that has worked very well for us for the last more than 20 years, and so we plan on building on this formula.
Thank you.
One quick question.
Yes.
On the MSO, because we haven't really talked about setting that up as a separate subsidiary. We had approved, I think, a year ago, as you pursuing the MSO, but it was run internally and not as a separate subsidiary. Why do we need to have a new subsidiary now for this?
Do you want to take it? Or?
I mean, I will just say that it is very standard in the industry to have the MSO as a separate corporation, and it probably makes a whole variety of functions more efficient and convenient. But I'll leave the details to you to explain.
Yeah, I mean, at the time, we were not asking for an Article 43. We wanted to have an MSO to essentially offer a self-insured product.
Okay.
So there wasn't really a necessity for the MSO to be outside of our current license. Now that we are asking for an Article 43 and an Article 44, it no longer makes sense for the MSO to sit under Article 44. The MSO will serve both. So it really needs to be an independent standalone subsidiary.
That makes sense. Thank you.
Okay.
Just to go back to the question of sort of reserve funding, and it says, it's noted that MetroPlus Health is going to be able to provide the funds and there's no impact on H&H as a corporation. Is there a liability for H&H overall if they're in terms of debt or losses of either of the two new subsidiaries? Yeah, I guess that's my question. What's the implications for H&H ultimately?
For this, yeah, so ultimately, on the balance sheet, MetroPlus has an operating unassigned surplus. We're able to support the initial reserve requirements, which are valued at 20%, not 12.5% as by the regulatory body. So we did increase the maximum that we think needs to be initially put up. Beyond that, there is still funding available within our balance sheet. MetroPlus's net worth is a total of $736 million. So the risk, while exists, is very limited and small as we move forward with our current projections for the future.
Thank you.
Thanks. And I had one quick question, which is, does this allow us to provide more choices in terms of Medicare Advantage plans under Article 44 that wouldn't be able to, or 43, I don't know, I'm losing what I mean. But you see what I'm saying? Now, are we able to provide a different set of Medicare Advantage plans than what we offer currently because maybe they're experience rated or whatever?
It is, do you want me to?
Doesn't the Medicare Advantage product that we offer today is the CMS approved product offering. It will remain within the 44 itself, but we do have flexibility to create different packages on an annual basis if there is a need or value add to the system. Right now, we offer three products under our existing Medicare license. That's the Medicare Advantage, our Platinum product, and we also have a MAP product that has just been brought online within the last number of years.
So we can offer different products from the ones we offer now under 43 that we wouldn't be able to offer otherwise.
Well, let me just take this. So this specific proposition is not impacting the Medicare lines of business.
Yeah.
Lauren was alluding to the fact that every year we can offer a different variation in different packages of Medicare. It is separate from what we're asking to do here. This request is not impacting Medicare lines of business.
But we will be able to provide more Medicare Advantage products if we ever wanted to do so under 43.
Under Article 44, there is no current plans to offer any new Medicare product under Article 43. So the plan is to continue to grow our current 3 Medicare plans under Article 44. So it's not significantly impacting the retirees or the Medicare line of business. This is really focused on more or less active employees or pre-retiree employees.
Okay, thank you. So Sally, one question, very brief, and we have 7 other
You're
resolutions.
going to have the same provider network, dental network, pharmacy, or are you planning on having different networks? 43, 44.
Good question. This is still under consideration. We are able to offer the same network, or we can modify it. It will all depend on the business needs.
Okay.
Okay, so let me then call for a vote on this. So I'll go one by one. Deborah Brown,
Yes.
Erin Kelly,
Yes.
Dr. Calamia,
Yes.
Dr. Christina Chang, Karen Sanhilaire,
Yes.
Robert Nolan.
I'm going to vote yes, but I also want to say that I want to thank the staff for being so prepared and well prepared, being able to explain everything that you did. And Andrea, our own Andy, going above and beyond and making another presentation even better than the one that you made when it came to the most recent contract negotiations with the city. So I vote aye.
Thank you.
Hello. Frida Wang,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra, and Jackie Rowe Adams.
Yes.
Jose Pagan, yes. Thank you so much.
Thank you.
Thanks. Okay, so let me move on. Remind board members that we have 5 more resolutions, so be very choosy on our questions from now on.
Disgusting.
So the next one, Dr. Calamia, can you read it?
I dropped it, went to 300.
Authorize the New York City Health and Hospitals Corporation, the system, to contract with NYSARC, Inc., contingent upon the inclusion of a termination clause in the contract that can be exercised after 1 year at the directive of the board if additional funding is not identified for this program. It's for respite services for adult patients with intellectual or developmental disabilities, IDD, for a term of 3 years with 2 one-year options exercisable only by the system for an amount not to exceed $8,500,000. This was improved with the contingency added at our MPA meeting.
Good afternoon. I'm Dr. Michelle Allen, the system's Chief Medical Officer, and I'm accompanied by.
Hi everyone, I'm Omar Fattal, Psychiatrist Deputy Chief Medical Officer and System Chief for Behavioral Health. And I'm joined with my colleague.
Dr. Jennifer Morrison Diallo, Director of Mental Health Services at Kings County.
I'm Wilbur Yun, Senior Director in Patient Growth.
So Dr. Fattal will take you through the presentation.
So we've included some information here for your records about respite services in general, but I'm going to focus on the NYSARC respite program itself. That's the question for today. It's currently the only respite service in New York City for adults with intellectual and developmental disabilities. It has been operating since 2019, and it provides 2 essential services. The first one is a 5-bed respite in Brooklyn for individuals who can be connected and enrolled in OPWDD services, but are pending approval and are in need of housing in the meanwhile. So during their time at the respite, they receive care coordination, psychological and behavioral support, peer counseling services and vocational rehab, groups, and 24/7 clinical care. This program also provides psychological testing for patients throughout our system to aid in the enrollment for OPWDD waiver services. The admission criteria to this program, there are two things that must happen. First, the patients have to be in an NYC health and hospital facility. That could be a CPAP or a psychiatric inpatient unit or a medical inpatient unit, but they must be able to be connected to OPWDD waiver services. And two, they must have proof of neurodevelopmental disability prior to age 22. Because without those two things, the respite program cannot link these individuals to OPWDD services, and therefore they're unable to find housing for them. So the goal from this is to move people, transition them into the community, and not have them stuck in our emergency rooms and inpatient units for long periods of time. We've been tracking the metrics of this program since it started in 2019, and the results have been impressive so far. The program has served approximately 8 to 10 people per year, and among the individuals served, there typically hasn't been a long wait list. We've had 0 readmissions since we started this program. The length of stay has ranged from 82 days to 257 days, and the number of successful placement has ranged from 6 people per year to 11 people per year. And the total savings has ranged from a little bit more than $1.1 million to a little bit more than $2.6 million. And we did a detailed analysis of the cost comparison. On one hand, what is the cost of being in a hospital bed? On the other hand, what's the cost of being in this program? And as you can see in the table, the respite is much less expensive than a hospital bed. As far as reimbursement, currently, we do not have reimbursable services through this program, but we are considering several options going forward. We're trying to find avenues for the qualified healthcare professionals who are on staff in this program, like social workers, psychologists, psychiatrists, to be able to bill for the work that they're doing, similar to how Mobile Crisis bills for in-community services. And we are working with our partners at OMH, the Office of Mental Health, and OPWDD, the Office of People with Developmental Disabilities, to explore funding streams to help cover the cost. This is the summary of the history of this contract. It started in October of 2019, and it's had multiple extensions and renewals since then. The current extension that we're in was from January 1st, 2023, and it's due to expire on March 31st, 2023. So what we did is an RFP in October of this past year, and we had multiple vendors apply. 2 were advanced to the last stage, and the evaluation committee evaluated them, and NYSARC was selected as the highest rated proposer. And for your records, we have the criteria for the RFP, the minimum criteria, the substantive criteria. We've listed the members of the evaluation committee. And this is the details of the performance of NYSARC. And going back to the ask from the beginning of the presentation, we're here to request that the board authorize New York City Health and Hospitals Corporation, or the system, to contract with NYSARC Inc. or NYSARC contingent upon the inclusion of a termination clause in the contract that can be exercised after 1 year at the directive of the board if additional funding is not identified for this program, which is a respite service for adult patients with intellectual or developmental disabilities, for a term of 3 years with 2 one-year optional exercisable only by the system for an amount not to exceed $8.5 million. The anticipated contract start date is April 1st, 2023. As far as MWBE status, according to the minimum criteria, all vendors had to be nonprofit community-based organizations which are not eligible to be certified MWBE. So procurement that solicit to these firms are excluded from the MWBE program. Additionally, NYSARC is self-performing these services, and the EEO status is approved.
Thank you. Any questions from board members?
What's the denominator of people with developmental disabilities, just in Brooklyn, I guess, is where you have here, just to get a sense of like how many people you anticipate serving through this contract?
Yeah, we can answer that. I think the more important denominator is people who are in our facilities. The purpose of this respite is to decant our emergency rooms and inpatient units because people with intellectual disabilities sometimes get admitted, but then it's very, very hard to placement because they could be eligible for OPWDD waiver services, but they don't have the paperwork or what's needed. So they end up waiting for weeks or months in our EDs. And the purpose is to be able to move them to this respite so that you can free up capacity for people who have acute need.
It's across the 5 boroughs, so this program does serve, it's located in Brooklyn, but they do take individuals from all of the health and hospitals facilities. And there's quite a need out there. I can't put like an exact number on it, but I mean, it's millions of people throughout the 5 boroughs, just with this diagnosis. And many of them, not millions, but many do not have an adequate place to live. And then what ends up happening is they're told to go to an ER or some inpatient stay to get housing. So this is a direct solution to help them, rather than sitting in the hospital setting, to actually go in the community and be able to have exposure in the community, have success, and be able to be placed successfully. So there's not an exact number I can give you off the top of my head, but there's many people that fit this need across the 5 boroughs.
How many do you see? How many do you see within H&H facilities?
I think we can get back to you on. We don't have the definitely not millions, but we can get back to you with more specific numbers. Yeah.
Curious.
Yeah.
Thank you. Any other questions?
Are people ever placed anywhere other than an OPWDD facility?
From this program?
From this program?
No.
No.
They have to be in a voluntary agency through OPWD, and there's many throughout the 5 boroughs, but they're all placed within the OPWD certified setting.
Just the therapeutics of the setting, could you just say a little bit about that and how much we will work to try to help people become more independent?
Sure. So they're fully staffed around the clock with different support staff, but there's a lot of clinical staff that are specifically trained to work with individuals with complex needs with intellectual disability, plus behavioral health needs and medical needs. So this population also has really complex medical issues as well. So they have nursing staff in the home. They also have licensed clinical social workers, psychologists, and a program director who also are, licensed level individuals. They actually this year with the most recent contract prior to this one that was approved, they've actually also included other therapeutic programming, such as licensed creative arts therapists that they've contracted with that come in and do different type of trauma-based and clinical-based services. They also have a peer counseling program built in, so they actually come into the house and work with these individuals. And some of the individual clinical programming includes working with things like vocational skills and job readiness, or just maybe activities of daily living, because this population has real struggles with basic things like using the bathroom and showering, even at an adult age, which is sometimes hard to believe. So they work with the individuals around the clock and really try to teach them the skills they need to succeed in the community, because otherwise, for readmissions and things of that nature, where they can't be adequately met in the community at the new residential placement. So anything that they're learning through the clinical staff there has to be able to be generalized in the new setting. So they work really hard with that. And I think one success among others of this program is that whatever they're teaching, they actually teach the new provider that they'll be going to, they'll be transitioning to from that respite house.
Okay.
So when the person transitions there, they have like weeks worth, actually months to some people, because it takes a bit of time to get them placed, of training with that new provider. So that way they're able to actually learn who the individual is and what kind of supports they need so they have success. So that's with the clinical team that's staffed at that house.
I just wondered what percentage of your projected population might be those who you would seek to help them get more independent living?
Many of, you mean in the house or just generally speaking?
any vision you have about your future patients.
I think that the purpose of the respite is temporary until we place them in a more permanent housing situation.
Okay.
Yeah.
Yeah. Lots of program, huh?
Okay, one more question.
Very quickly, I just looking at your missions, and it includes CPAP, psychiatric inpatient, medical inpatient, and I guess a concern I have is that you want to have a cohort of individuals who are similar, who have intellectual developmental disabilities, but you also want, if they're psychiatric issues, that they be ones that are not impediments to being able to build the kind of community you're looking to build. So that in trying to deal with the backups at H&H, we still are very careful in screening folks that are going to ensure success for the group as a whole.
Yeah, the people who are at the respite.
I'm sorry.
No, I'm saying you're talking about the people who end up at the respite.
Yes.
Yeah.
Yeah.
Yeah, actually, Jennifer works on a unit at Kings County, which is an inpatient IDD and mental health unit. So we do have that option for those patients who need that acute care, who have dual diagnosis. And so we have that as an option. This is meant to be more as a respite, more of a temporary housing, working with those individuals during that time to be able to help them to move on to more permanent OPWDD housing.
Okay, thank you.
Okay, so then let me then call for a vote. Deborah Brown,
Yes.
Erin Kelly,
Yes.
Salamia,
Yes.
Christina Chang, Karen San Hilaire,
Yes.
Robert Nolan,
Yes.
Barbara Lowe,
Yes.
Vida Wan,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
and Jackie Rowe Adams.
Yes.
Sapagan, yes. So, thank you so much. Resolution approved. Let's move to the next one. Dr. Calamia.
Thank you. Authorizing the New York City Health and Hospitals Corporation, the system, to exercise a best interest extension for 3 months on its existing contract with Crott Hall Facilities Management, Inc., Crott Hall, for biomedical program management for an amount not to exceed $9,369,806 for the 3-month extension period. This was presented on the February 6th MPA meeting and approved.
Good afternoon. I'm Joe Wilson. I'm Senior Assistant Vice President of Supply Chain. Crott Hall Facilities Management manages biomedical services for all New York City Health and Hospitals locations, including acute care, Gotham, long-term care, as well as correctional health. The agreement provides management staff as well as equipment maintenance. City Health and Hospitals contracted with Crott Hall Healthcare Services as a result of an RFP in 2014. The Crott Hall Biomed agreement was board approved with a not to exceed amount of $252,884,799 for the term of the contract. The RFP and agreement were managed by the Office of Contract and Control until 2017, when the Office of Contract and Control merged with Supply Chain. Since that time, the agreement and relationship management has been in the hands of Supply Chain. Over the course of the agreement, the scope of work expanded to cover services such as dialysis, laboratory, chillers, stretchers, correctional health equipment, IT support, warehousing, and transportation, and the current agreement expires March 31st, 2023. Per the operating procedure 100-05, New York City Health and Hospitals has issued an RFP to identify a provider and award an agreement for the next 10 years. The new RFP scope of work has evolved from break-fix to full management program, which includes equipment repair, maintenance, equipment management, IT support, warehousing, and transportation. The initial timeline to complete the RFP was extended due to the enhanced scope of work. Timeline to develop the scope for each service vertical with facility leadership, IT, nursing, and other service lines extended the current target date. New York City Health and Hospitals seeks to extend the current agreement with Crott Hall Healthcare for an additional 3 months under the best interest extension to provide services until a new agreement is implemented. The next slide is a little bit more detail of what is changing in the program, where currently today we are an equipment management program. We will be adding in biomed IT support since medical equipment has evolved and are greatly intertwined with our systems such as Epic, PeopleSoft, and PACS, and also to help us with any vulnerabilities or mitigation as pertains to IT security. We've added warehousing and transportation to take stress off our facilities from managing large implementations, and equipment maintenance, which is the process in which movable equipment is properly cleaned on the floors and available to nursing in a much quicker, much safer fashion. The vendor performance from Crothall has been very strong. They've been a good partner over the past 9 years, and were an exceptional partner during COVID, going above and beyond both waves. The request, authorizing New York City Health and Hospitals Corporation to exercise a best interest extension for 3 months on its existing contract with Crothall Facilities Management for biomedical program management for an amount not to exceed $9,369,806 for the 3-month extension period, which will bring the total new not to exceed to $262,214,605.
Thank you. Any questions? Okay, hearing none, then I want to call to a vote. Deborah Brown,
Yes.
Erin Kelly,
Yes.
Dr. Calamia,
Yes.
Dr. Chang,
Yes.
Karen San Hilaire,
Yes.
Robert Nolan,
Yes.
Barbara Lowe,
Yes.
Vida Wang,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra,
Yes.
Jackie Rowe Adams,
Yes.
and Jose Pagan, yes. Thank you so much.
Thank you.
So let's move to the next one, number 7, and that's authorizing New York City Health and Hospitals Corporation, the system, to execute a contract with Gemco Electrical Contractors, Inc., to complete an upgrade of emergency electrical service type 1 at NYC Hospitals Metropolitan Hospital Center for a term to equal the duration of the proposed construction project for an amount, including a 10% project contingency of $745,300, not to exceed $8,198,300.
Hi, good afternoon, everybody. I'm Manny Sayers from the Office of Facility Development, joined by colleagues Menji Endar and Tamika Campbell, also from the Office of Facilities Development. Menji Endar will start guiding you through the presentation.
Good afternoon, everyone. So emergency electrical separation of the emergency power within a hospital is a requirement of NFPA code and also a regulatory requirement for CMS and New York State DOH. The emergency electrical separation requires the emergency power within a hospital to be separated into 3 branches: critical, life safety, and equipment. Currently, Metropolitan is out of compliance with this requirement, and they were cited by CMS, and they were put together a plan of correction and were granted a time waiver for the duration of construction to complete this work. Currently, we're here seeking approval to enter into contract to complete this work. That will take approximately 30 months to bring the, 30 minutes, I wish it was that fast. 30 months to bring the system, to bring Metropolitan up to compliance with the code and satisfy the CMS citation. I'll pass over to my colleague Tamika Campbell to talk about the procurement and the contract details.
So the overview for procurement in September 2022, there were 2 site visits, site tours for approximately 8 bidders. In October of 2022, we received 3 proposals, and in October 28, 2022, we had pre-qualification meeting for the lowest responsible bidder, which was Gemco. The construction contract for Gemco was sourced via public bid. Gemco was the lowest of the 3 bidders with an MWBE percentage of 31. And of that rate, that 31%, we have 5 vendors, which totals to the amount of $2,310,430. The contract for Gemco is $7,453,000. Gemco is currently one of our JOC's electrical contractor for the 2020 to 2022 contract, and also previous JOC's electrical contractor for 2018 to 2020. Evaluations of both contracts, the ratings were 84% and 93%. Additional rates listed in Knox. They had 2 excellent and 4 good ratings. This project is expected to begin the spring of 2023 and expected to be completed fall of 2025. next. So this is just, these are performance evaluation descriptions, which overall rating for Demco was a rating of good. So the project breakdown, we have construction at 4,453,000. Sorry, apologies. 7,453,000 with a contingency of 743,300, with a total contract value for $8,198,300.
And finally, just seeking approval to enter into contract with Gemco to complete this work at Metropolitan for a term of 30 months with a 10% contingency of $745,300 for a total not to exceed of $8,198,300. Thank you. Well, happy to take any questions.
They're out of compliance now with this emergency electrical system separation. Is there anything negative that can happen as they're coming into compliance?
We've had some issues with the electrical distribution system in Metropolitan this week. However, they do have emergency power and emergency generation to mitigate that. So fortunately, we maintain that system very well. We test it regularly, and it was able to support the needs of the hospital during this electrical emergency. So we do have a contingency plan that can support the hospital if needed while we complete this work.
Okay, terrific. Thank you.
Any other questions? Okay, so let me call for a vote. Deborah Brown?
Yes.
Erin Kelly?
Yes.
Dr. Calamia?
Yes.
Dr. Chang? Yes. Karen San Hilaire?
Yes.
Robert Nolan?
Yes.
Barbara Lowe?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero?
Yes.
Anita Kawatra?
Yes.
Jackie Rowe Adams?
Yes.
And Jose Pagan, yes. Thank you so much.
Thank you.
So let me move to number 8 on the list of resolutions. Is amending the resolution adopted at the September 2022 meeting of the Board of Directors of New York City Health and Hospitals Corporation that authorized an 18-year lease with 90-02 QB Holdings LLC for approximately 40,000 square feet on the ground floor of 90-02 Queens Boulevard, Elmhurst, Queens, New York, for use by NYC Health and Hospitals Elmhurst and Queens for administrative office space. Such amendment to correct the name of the landlord to be 9002 Commercial Unit LLC. Presented directly to the board. I don't know. Any questions from board members for Jeremy?
No.
This?
Should Jeremy just explain what caused this?
Yes, sure, but very brief.
Correcting a mistake that the landlord had made when it gave us the name of the entity that owned the condo unit that this clinic is going to be operated out of. So this is a building with a number of different condominium units. I think they're all controlled by the landlord, and they just got confused about which of their companies was the owner of this particular unit. So this is just correcting that mistake. We're about to sign the lease, and we want to make sure that the entity that we're signing the lease with is actually the entity that we had authority to deal with.
Thank you so much. And on that note, I would like to call for a vote then. Deborah Brown? Yes. Erin Kelly? Yes. Dr. Calamia?
Yes.
Dr. Christina Chang?
Yes.
Karen San Hilaire?
Yes.
Robert Nolan?
Yes.
Barbara Lowe?
Yes.
Frida Wang?
Yes.
Sally Hernandez Piñero? Anita Kawatra?
Yes.
And Jackie Rowe Adams?
Yes.
Jose Pagan, yes. Thank you so much, Jeremy.
Thank you.
So
Back again?
Back again.
That went well. Number 9.
Motto or something?
Right, number 9 is authorizing New York City Health and Hospitals Corporation to execute standby requirement contracts with Array Architects PC, Perkins Eastman Architects, DPC, Gensler Architecture, Design and Planning PC, NDBJ Architecture PLLC, BDP Architecture PC, Moody Nolan Inc., and Perkins and Will Architects PC to provide master planning and facility assessment services across the system over a term of 6 years, with the system holding 2 one-year renewal options for an amount not to exceed $16 million. $16 million. This was presented to the Capital Committee on February 6, 2023.
Thank you, Dr. Pagan. Again, my name is Manny Sayas from the Office of Facilities Development, joined with Menji Indar and Al Channer, also from the Office of Facilities Development. A little bit of background regarding this request. This is a comprehensive master plan that is needed because our buildings and our major infrastructure across our campuses are at various ages and conditions and are not documented in a consistent manner. Aging buildings and systems do not conform with today's current standards for state-of-the-art and delivery of care, and our major infrastructure components are nearing the end of their useful life. The facilities master planning will be done in sequential rather than concurrent order. This would ensure that all facility leaders, OFD, and the selected vendors will have adequate time to meet the expected outcomes of this work. This work will be awarded to a pool of 7 design firms to complete over several years, and if at the end of the contract completion there are open projects, the contract will extend to ensure project completion. With that, I'd like to hand it over to Al Channer.
So the master plan and assessment is to develop a comprehensive physical assessment to better align with the goals of the H&H Corporation. It's also to better utilize our existing and future capital infrastructure and realize the efficiencies of thorough planning for our clinical services. This will allow for proper growth and patient safety in all of our facilities and give us a proactive look at all of our campuses to make sure that we're meeting the needs of the community, as well as giving our clinicians the proper support that they need to provide their services to the community. And it also provides a more uniform long-term capital planning goal. The master planning process was kicked off with an RFP. 7 vendors was awarded for this engagement. We had many submittals for this process, and over a thorough review of the RFP proposals, we narrowed it down to 7. We are setting up a governance team that will involve clinical and operational leaders of the facilities, central office, and our OFD department. And each master planning effort will be kicked off at the facilities with the engagement of the facilities leadership and central office leadership. Check-in with the governance team during the process will be done to make sure that we are in alignment with goals of H&H as well as the individual facilities, and this will all culminate in the final report with the facilities leadership and the system governance team. RFP criteria is just making sure that all of these vendors are able to support this initiative. So they all have substantial years of experience within the field, and as well as their approach to this type of project. And our capital evaluation committee is spread across different aspects of H&H, including OFD, facilities, MPA, finance, EITS. The procurement was published to City Record in October, and with pre-proposal from 30 vendors and submitted in mid-October. We did a review of all the proposals in September and culminated in the committee doing debrief in October and presenting the final rounds in November of this year. Vendor presentations were just conducted in early January with Array Architects, Perkins Eastman, Gensler, NBBJ, BDP, Moody Nolan, and Perkins & Will as the presenters. Perkins Eastman has evaluations in our mock systems. The other vendors are very highly rated, but they do not have evaluations in our mock system. H&H has not recently worked with BDP, Perkins & Will, but these are 2 well-established healthcare firms within the industry. The MWBE analysis is presented on the next page. All vendors meeting our minimum of 30%, with the exception of Moody Nolan, who is at 100% as an MWBE. the Office of Facilities Development is seeking approval to enter into contract with Array Architects, Perkins Eastman Architects, Gensler Architecture, and BBJ Architects, Moody Nolan, and Perkins and Will for a not to exceed amount of $16 million and a contract term of 6 years with 2 one-year renewal options. And the annual budget is expected to be about $2 million to complete 2 to 4 facilities based on the size and complexity.
Thank you so much. Any questions from board members? Sally?
Understanding the concept of a master plan sequential in a system that is inherently like continuing to operate over the next 6 to 8 years, you'll be doing this sequentially. Meanwhile, each of the hospitals will have their own, I'll call them master plans, but there'll be at least 1 to 5 year plans, which on the capital side are not really long-term plans. And you have government agencies putting in money for designated projects. I'm just wondering how you tend to maintain the flexibility and of the sequential planning in a system that is just by definition, constantly moving.
I'll take that. Okay. So that's a very good question, and that's one of the challenges of master planning. The way that we are looking to approach this is we're looking at the goals of H&H as a whole. We need to operate as a system, so we want to make sure that all of our facilities are working in unison with each other. So that's the process of doing it sequentially so that we could dedicate the time and effort to really analyze the data at each location and able to sync that up with the existing projects that we have going on, projects that are on the books to be performed, as well as to say what is the ultimate vision for each facility. And that takes an extraordinary amount of effort and time, not just from the facilities, but also from our partners within OFD, as well as the central office leadership. And it's just mapping it out so that we have a cohesive vision moving forward for the organization without really hindering the progress of the work of the clinicians.
Sally, if I may, so in addition to what Al mentioned, I think doing it sequentially, if we were to do it all at once, we would have a huge ask in terms of financial ask to fund all of the initiatives that would come out of the master plan. So doing it sequentially allows us to do this over, to kind of phase that over a longer period of time and have incremental asks as opposed to one large system-wide ask. So we have master plans that are being done every year that will provide some asks for 1 or 2 facilities that we can, we'll continue up, we supplement that with our new needs ask, which we do 3 times a year with the city, and we will have incremental financial numbers over that 7-8 year term. So it allows us to break it up instead of having one lump sum new needs.
And I would just lastly add that it gives us the opportunity to set expectations accordingly as we run through the sequential order. We're not looking to do the master plan so it could be some pie in the sky proposal that we can never achieve, but really more focused planning as we move through the process, as we continue to learn while we move through each facility.
So the Bronx can't be last.
I agree. I'll vote for it not to be.
I don't want to go there.
It's necessary for me once again to state that the company Moody Nolan is a company unknown to me at all. I don't know Moody. I don't know Nolan. I see 5 of the 7 are architects. I'm not aware there's an architect in our family at all. So because of that, I will be voting on this matter since, to the best of my knowledge, I have no idea who this other Nolan is.
Thank you. Thank you for the clarification.
It's the 3rd time I've had to say that in the last couple of years.
Any other
That was my
comments or
question.
questions? That was your question? Okay, so let me call for a vote then. Deborah Brown?
Yes.
Erin Kelly?
Yep.
Dr. Calamia?
Yes.
Dr. Chan?
Yes.
Karen St. Hilaire?
Yes.
Robert Nolan?
Yes.
Barbara Lowe?
Yes.
Frida Juan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra?
Yes.
Jackie Rowe Adams?
Yes.
Jose Pagan, yes. So resolution.
Thank you.
Thank you so much. Let me then, any more things? So the President's report from Dr. Katz is included in the materials and is submitted into the report. If you have any questions, please email them to either Colicia Hercules or me. The committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? So hearing none, the board meeting is adjourned. Thank you so much.
Thank you.
Thanks.
This meeting is no longer being recorded.